So, hi everyone, and welcome to Diabetes Research Connections virtual gathering. This is our fifth one, and we are very excited today. First, as we go into this time, I want to just give a couple of pointers on how to best view everybody. As you're looking in the upper right corner, you see gallery view or speaker view. We recommend selecting speaker view. Then you can see who is talking as they are talking live. So we're so excited that you can all join us. And I am thrilled to introduce Ann Hanneken, MD. She's a vitreoretinal surgeon at Scripps Memorial Hospital and associate professor of molecular medicine at Scripps Research Institute. And Franz Vinberg, Ph.D., who is assistant professor of ophthalmology and visual sciences at John A. Moran Eye Center, University of Utah. So welcome. Thank you so much for you both being here. We are thrilled to have you today and hear everything you have to say. Dr. Vinberg is one of our researchers that we are thrilled to support, so we will get to share some information about that at the end and share where you can read more about the exciting research he's doing. So please join me in welcoming both of these incredible scientists, researchers, doctors. We're so thrilled to have you here and to share on preserving retinal cell survival. So I'm going to hand it over. I know that Dr. Vinberg is going to show some slides and Dr. Hanneken is going to open, and I'm going to leave so you can see those who are speaking. If you have questions, again, please engage in the chat feature, and we are excited to answer those at the end of our time together. If we do not have enough time, don't worry, we'll follow up with you and we will answer questions at a later time. So I'm going to hand it over now.
Okay, yeah, thank you very much for having us here, and I will share my screen now and we'll start to present some of our research.
Hello, everyone. I'm Dr. Ann Hanneken, and I'm delighted to be able to update you on the work that is being supported by the Diabetes Research Connection and its relevance to the treatment and management of diabetic eye disease. As you all probably know, since you're well versed in the diabetes arena, diabetic retinopathy is a very common side effect of diabetes. Up to 35% of diabetics will develop some form of diabetic retinopathy during their lifespan, and in some cases this can lead to severe visual loss. I am a practicing retina specialist and a basic researcher as well, so we think about current treatments, how to make them better, how to improve and envision future treatments that'll change the landscape of managing vision and visual loss. Today's talk is on preserving retinal cell survival and function for potential clinical studies in type 1 diabetes. And this is really a very ambitious protocol, one that we are very excited about because we're actually making some progress on it, and you'll hear much of that from Dr. Vinberg. This particular talk is focusing on new innovative approaches to repairing nerve damage in diabetic patients. First slide. So diabetic retinopathy is typically thought of as a vascular disease. And for the last 100 years, there's been a wealth of publications and lectures about the significance of diabetic vascular abnormalities and how it leads to visual loss. You'll see these areas of hemorrhages in the back of the eye on the right side of your screen, which is a diabetic eye, compared to the normal eye on the left side of the screen. We're showing you the difference for comparison so that you can understand what really happens in the back of an eye in a patient with diabetic eye disease. So the central vision is the fovea, right in the center, which is marked by the dark orange color. That's the area you use for reading and fine focus. The remaining retina is used for peripheral vision, and it's nourished by the large retinal arteries and veins that enter and exit the eye through the optic nerve, which connects the visual pathway to the brain. On the left side, the diabetic eye has hemorrhages, has these white patches, which are typically areas of lipid accumulation, which interrupt the normal function of the nerves, causing visual loss. And in some cases, there's actually scar tissue growth and abnormal blood vessels that grow across the surface of the retina and cause vitreous hemorrhages and sometimes retinal detachments. New slide. What's becoming more, gaining more attention these days is the significance of nerve disease in a diabetic eye. While we focus primarily on diabetic vascular disease, the nerve function and the dysfunction of these nerves is something that's much more difficult to treat. Current approaches to treating diabetic nerve disease is really quite limited. Next slide. While we have lots of treatments for the vascular abnormalities, such as injections that reduce the swelling and the leakage of lipid and hemorrhage from blood vessels, and we have surgery to reduce the scar tissue that grows across the surface and remove vitreous hemorrhages. We don't really have good treatments for diabetic nerve disease. The nerve damage is, at this point, very difficult to prevent and to repair. So this leads us to think about far-reaching ideas, new approaches, stem cell replacement or retinal cell replacement. These are all considered fairly audacious goals, but these are goals that we're working on in a collaborative team. Next slide. So a few years ago, we were envisioning what it would be like if we could replace retinal cells in a damaged diabetic eye. And as many of you know, once the diabetic eye disease becomes pretty significant, it's very, very difficult to get those nerves to function again. So as we approach this, we envisioned 3 different phases for retinal cell replacement. We envisioned the phase where we would work on maintaining a viability of patches, of macular patches in autopsy eyes from human donors. And then we thought, well, if we could accomplish phase 1, we would then start working on mechanisms and protocols to induce synaptic remodeling in the event that we would be able to replace retinal cells into a damaged eye. We would need to get those cells to connect with their neighbors, and that we see as challenges in phase 2. Phase 3 of this project would be focused on developing techniques for a surgical transplantation of retinal cells to replace the damaged neurons. Each of these is a milestone of research, a tremendous amount of work, and work that's far-reaching and audacious. Will it work? We have no idea. But the work that the Diabetes Research Connection is supporting in our program is based on phase 1. Next slide. And in phase 1, we're investigating the challenges and the technical feasibility of maintaining a viable macular patch in a post-mortem eye for an extended period of time after death of the donor. This is a project that is not simple, obviously, and requires a large collaborative team. Next slide. So to approach this about 5 years ago, I elicited the help of Dr. Franz Vinberg, who is one of the most world-class electrophysiologists around. And his interest in the clinical translation attracted me to recruit him as part of our team. In addition, we started working closely with eye banks, such as the San Diego Eye Bank, and organ donor programs. We also started working with investigators from the Salk Institute, including Sachin Panda, who has a long history of interest in ocular physiology and ocular disease. And by putting together this large consortium, we were able to actually envision approaches to try to induce the future of retinal cell replacement in the human damaged diabetic eye. Where do we start? Well, we start with trying to maintain the survival of an autopsy eye after death. And this was work that we began many years ago, and I'm going to let Dr. Franz Vinberg take it over and talk with you and explain how we approach this, where we started, where we are today, and where we are going. Frans?
Okay, thank you, Anne, for introducing to this topic. And so I will be here now, the one who will be really presenting a data bliss. And I'm trying to make it as easy to understand as possible. So this data is basically showing some of the data that form the premise to our DRC proposal, and also some very fresh data that we have collected by using the DRC funding. So I'm a basic scientist by training, and I'm a retinal neuroscientist, and I have studied retinal neurons for more than 10 years. And about 5-6 years ago, we met with Anne at ARVO conference, and I really liked her enthusiasm, and I thought that our collaboration could really lead to somewhere. At that point, I was actually a postdoc at Washington University, and our collaboration actually led to career transition funding, K99 funding, and we started to collaborate already at that time. And now that collaboration just has continued and intensified, and I see that it will really continue for a long time. So some of the challenges that we have, and this all is now focused on this phase 1 study. And in this phase 1, one of the challenges is that that when we are harvesting or when we are recovering human eyes from donors, human donors, there is necessarily a time delay from death to recovery of the eyes. And what are these time constraints that limit our possibility to restore and, on the other hand, maintain viable retinal patches from human eyes? And to kind of understand this more, we first conducted experiments that we call in vivo electroretinogram. So this technique is technique that you can actually do in clinics from awake human patients. but you can also do it from anesthetized animals like here from mice. And in this technique, you are measuring the electrical activity and light evoked electrical activity of retinal neurons. And in practice, what you do is that you have a contact lens which has an electrode. And then when you shine light, in this case to the mouse, there will be electrical activity in the retina that is in the back of the eye. When light is received by photoreceptors, it is converted into electrical signal, and then this signal is transmitted to the second order neurons, bipolar cells, and output neurons of the retina ganglion cells, which project their actions through this optic nerve to the brain for visual perception. So here you can see example data from anesthetized live mouse. So we shine light here, and you can see this first negative deflection, which we call A wave. And we know this part of the signal comes mainly from the activity of photoreceptor cells in the retina. And then this is followed by a positive deflection, which we call B wave. And this B wave, we know that is mainly originating from activity of second order neurons, mainly bipolar cells. And now what we wanted to understand here is that what happens to this electrical signaling in the retina after the animal dies. And so here you can see that after the mouse has been euthanized, we again give the same flash of light as we gave here, and we see that we have already significantly reduced specifically B wave, and then already 20 seconds after death. And then if we go more, a few minutes after death, we basically lose all of this B wave indicative of bipolar cell activity. We still have some photoreceptor activity left. However, within 5 minutes, we find that basically almost all the electrical activity from the retina is vanished and abolished. So this, of course, doesn't look that promising. So this would mean that the neurons are very sensitive to this post-mortem conditions where we have severe hypoxia, acidosis, among other things, and they really don't like it, and they lose function very quickly. However, what we don't know based on these experiments is whether we can actually restore their activity and these light-evoked electrical signals if we put the retinal patches into conditions where we provide again normal oxygen, normal pH, and all the nutrients to the neurons. And this is what we did here. So this technique is something that I have been involved a lot in developing for the past almost 10 years, and we call it ex vivo electroretinogram. So in this technique, you essentially measure also activity of retinal cells, and we call it ERG also. But in this case, what we do that we can enucleate the eyes from euthanized mice, and then we can dissect the retina out, shown here in pink. And then when we put this retina into a custom-built specimen holder here, we can then perfuse the retina with nutrients, with high oxygen concentration, and we can try to find conditions where we could be able to revive or restore the function of these retinal cells even after the animal has died. And we have electrodes. We similarly we shine light, and when we shine light to these isolated retina, they actually respond very similarly as we saw in those in vivo experiments. We have this negative deflection A wave, positive deflection B wave, and this is from the retina that has been dissected from the eye that was enucleated immediately after euthanasia. However, we can also enucleate the eye later, let's say 30 minutes after euthanasia, and then take the retina out, put it into these conditions where it will get the nutrients, oxygen, and so on. And we can actually still, even 30 minutes after death, we can record significant light responses. So I think we can see it better here when we quantify. So this dashed line here shows what I showed in the previous slide, where we can see that we have very quick abolishment of the retinal light signals in vivo. So in few minutes, we don't have any light activity anymore. However, then if we take these retinas out, even 15 minutes after death or 30 minutes after death, we can actually restore a significant amount of this signal. So this is a little bit more promising. So now it seems that we have time window of 50 minutes, 30 minutes or so, maybe to get the retinal patches from human donors and restore their activity. Of course, this study was with mice, and we are not so much interested about restoring vision in mice, but we are actually interested in restoring vision in humans. So we next tried to establish the protocols to restore these light evoked responses in human retinal patches, and specifically in the macula, which is very important for our daytime color vision. So here we first did experiments using monkeys or macaques, and in these experiments the eyes were enucleated almost immediately after euthanasia, and then they were put into these conditions, the same conditions as we used with mice, and then we conducted these ex vivo electroretinogram recordings, and as you can see here, these are actually a cone photoreceptor responses from a macaque macula. And macaques or monkeys, they have a very similar macula compared to the humans, basically primate macula. And now we wanted to see how these compare to the human macula, light evoked responses in the human macula that we get from human donors. And for this, we actually first started from research donor eyes. So sometimes eye banks cannot use the corneas for transplantation, and these donors are termed as research donors. And with research donors, we typically have at least 3 hours, but more commonly even 5 hours delay from death to recovery of the eyes. And this, of course, potentially is the problem, as we noticed from the mouse experiments, that there is a decay of these responses after death. And here is one example, light response family from a macula of a human donor. The eyes were recovered 2 hours, 40 minutes after death, and we can record some responses, but they are clearly smaller than in these freshly enucleated non-human primate eyes. And then we thought that, okay, it's good, this is promising that we can still record some responses here. However, they are not really perfect, and we should really improve these protocols. And this is where our collaboration with Dr. Hanneken, LifeSharing, and San Diego Eye Bank came into really live, and we have now built a setup to record these ex vivo ERG, to do these ex vivo ERG recordings in Dr. Hanneken's laboratory at Scripps Research Institute. And in these experiments, we are notified for a human donor, and it is scheduled for some time, and then Anne can go there together with other transplant teams, for example, heart transplant team, lung transplant team, and then after they have done their job, Anne can go in and recover the eyes for us. And typically we are talking about 30 minutes, 60 minutes, Anne can correct if I'm wrong, delay for eye recovery after death. And this is then what we have done using those protocols and this approach. And we can see that we have significantly better responses as compared to what we had from this research donor. And this is now what we are continuing to do and using these and still to improve our protocols. And here, for example, you can see very recent responses that we recorded this August. I actually drove to San Diego because of the pandemic. I couldn't fly, so I drove to San Diego, and we were doing these experiments from one human donor, and we recorded responses to red light from red cones in human macula to yellow light, which will activate both green and red cones in the human macula. And you can see that they look pretty nice, but if you remember the responses that I showed earlier from these ERG recordings, you may remember that we had this positive deflection in these responses. And you can see that we don't really see this positive deflection. And this is the challenge that we are still trying to understand, that what is the time course after death that we are losing irreversibly this function of these second order neurons and bipolar cells. And on the other hand, what could we do to better restore these inner retinal signals also to get really viable retinal patches that can signal light all the way from photoreceptors to the output neurons, the ganglion cells. And recently we have tried to understand mechanisms for this loss of B waves, and we did these experiments now with mice here in Utah. So we used again ex vivo ERG, and then we tried to understand different factors that may contribute to loss of these B waves or inner retina activity. And here, for example, we had isolated retina that were first perfused under normal oxygen conditions, and then we exposed it to very low oxygen concentration. And you can see that very quickly we lose the light responses as expected. And this is comparable what happened in vivo after death in mice. And also we can do the same experiment where we expose these retinas to low pH, and also we can see very quick reduction in the responses. However, the next question is, okay, can we lose the responses, but can we recover them if we put these retinas back into the normal pH, normal oxygen? And here we can see that for the low pH, for the acidic conditions, we can expose these retinas to acidic conditions even up to 3 hours. And then if we put them back to normal pH, we can restore normal light responses. However, with hypoxia, we are doing a little bit worse. So with hypoxia, we really see that we lose some of the B wave, and we can never recover all of that. So it looks like this postmortem hypoxia really is our biggest enemy here. And just to review our kind of what we are doing currently and what we plan to do in the near future. So we next kind of want to understand better that what is that time limit, that how quickly we need to recover the eyes in the human donors that we can restore also the inner retinal function. And we are planning to do this very soon using pigs first as a model, but then of course hopefully that will inform us for the human donor experiments. And other thing that we have been doing is that, okay, if we can restore the A waves and B waves and the normal light signals, how long we can then on the other hand preserve. So what are the optimal conditions where we should store these retinal patches so that they will maintain their function all the way until they are supposed to be transplanted. And these are something that we also, we have done a lot with mice, and we know that we can go at least up to 20 hours. We have found conditions where we can maintain normal light signaling for for 20 hours. So we are still planning to push this limit even forward. And of course, we also want to do these experiments using pig and human eyes. So I think I will stop here. Maybe there was quite a lot of data. Hopefully it was to some extent understandable. And I want to acknowledge our collaborators at this point. So thank you.
All right, thank you so much, Dr. Vinberg. And I know that, okay, Dr. Hanneken, you are unmuted. We are all here. So one quick question. I know that we have some questions I think that Dr. Hanneken can answer, but I got a question for you, Dr. Vinberg, as you were sharing, and that was incredible. Thank you for the update, and thank you so much for including us into a closer look at your research. And again, I'll get to share with the community exactly where they can look into your project and how to get involved and receive updates from you. But one of the questions was, and you may have addressed this, some of our guests joined a little bit later, so I'm just saying it for everybody. They're curious if you can do research on living eyes. So there's a lot of conversation about, obviously, some retinopathy and doing these tests specifically on, like you said, mice and so on and so forth. They were curious, is that ever an option, and what would that look like?
I mean, so this in vivo ERG, I mean, if the question, I'm not sure if I understood correctly, but yeah, if you can do from living animal and a living patient. So yes, we can do this as I presented in the very beginning. I presented the technique which is called in vivo ERG, and this is something that Anne probably is doing in her clinic often. It's not something that's done too often, but it's relatively non-invasive. You don't have to anesthetize humans because humans can behave. For the mice, you need to anesthetize, and for the animals, you need to anesthetize. And the signal looks very similar to what we record from these ex vivo samples. So that's the strength here, that we can actually compare these ex vivo signals to those in vivo signals. And I have actually even previously published some papers to try to find the ex vivo conditions that correspond to those in vivo. And sometimes in ex vivo, we kind of do an overkill. So we have like 95% oxygen, whereas in real retina, it's only, let's say, something like 5%. So it is not, it is very interesting, and we can do both, yes.
Dr. Hanneken, do you have anything to say on that as well?
Well, Dr. Vinberg is correct. We use in vivo ERGs to study retinal function. It's particularly helpful when people have a family history of a retinal dystrophy, a retinal degeneration, something called retinitis pigmentosa or cone rod dystrophy. There's a number of different inherited diseases that cause blindness, and the in vivo ERG plays a very important role in helping us understand what the nature of that problem is.
Okay, so here is another question that we just received. So an individual said that their doctor told them that 50%, they don't know if this is true, so they said 50% of type 1 diabetics that are 20 years of age can and most likely will develop some symptoms of retinopathy. She said whether or not that's true, was there a certain age that she should have started getting eye exams? And if so, what would be a recommendation for a type 1 diabetic? Is there an age that they could be aware of as a parent or a guardian to begin eye exams to be able to uncover if they're having any symptoms of retinopathy?
Well, that's a very important question. And a lot of it depends on when the patient developed diabetes. I'd say that if it's someone who's had a very young onset of diabetes, say between 1 and 5 years of age, they should be seen in their late teenage years. The earliest I've ever seen diabetic retinopathy is probably an 17 or 18-year-old, and that's from someone who develop diabetes as an infant. Now, it's not very common that you develop it that young. And so if someone develops diabetes when they're 13, for example, it probably would make sense to be seen when they're 20 years of age. But anywhere in general between 18 and 20 is a good time to get a baseline examination, and that'll set the stage for comparisons studies when you get examined in the future. You know, maybe every 2 or 3 years if there's no sign of a problem, or more frequently if there is some evidence of some problem. Again, it really depends on the age of onset, and the control plays a big role. If there's very poor control of the hemoglobin A1C and the glycosylation levels, there's going to be more advanced disease and a faster progression. So these all play a role in the onset of diabetic eye disease. But in general, if someone's had diabetes for 20 years, there's a pretty good chance they will develop some degree of retinopathy.
Great. Okay, so we received another question. It says, while I love the research you're doing, I'm curious, can retinopathy be reversed through any type of better management of type 1 diabetes? Is it reversible, yes or no? And if so, how?
Well, that's another good question. You've got a great audience. So retinopathy can be improved with tight control of diabetes. Now that's an interesting point of discussion, because if you take someone who's in very poor control and put them in tight control, for the first couple years their retinopathy may actually get worse. And I explain this to people by saying that their eye's sort of in shock. It goes into shock when the sugar levels are brought back into a normal range. But after that point, the retinopathy can improve. And it'll improve much faster and maybe only with treatment. So while we used to do laser treatment to try to improve diabetic eye disease, now we don't use laser very often anymore. We have other medications that we use that reduce the vascular disease. But in general, you usually need some kind of treatment to reverse it. It doesn't necessarily reverse on its own, even if you have a great diet and you're taking lots of supplements. It's very difficult, if not impossible, to get that to happen.
It is actually very interesting for me to hear that the vision can even go worse initially when you start to control glucose, because what we have found in our research is that retina also can adapt to some extent to this hyperglycemic condition, and also high glucose can in some cases improve retinal light signals. So it could be somehow even related to this.
That's interesting.
So I think you actually kind of answered this question. You were mentioning laser treatment and medication. Another question was, what are current treatments for retinopathy?
Well, it depends what stage of retinopathy the patient has. If it's early background, what we call background diabetic retinopathy, which consists of scattered hemorrhages and some microaneurysms, we don't do a whole lot. You don't really need to, because typically that's just an early sign and treatment isn't necessary. And that makes people feel good, knowing that they can simply be monitored. They don't have to go in and have any treatment. Laser treatment is falling out of popularity now. If someone gets to the point where they've got swelling and their central vision is getting blurred because they've got edema, or they've got blood or lipid deposits, we tend to use some of these newer treatments that have been developed in the last 10 to 15 years called anti-VEGF medications. And those are miracle workers. It's just the biggest advance that we've had in 50 years for a diabetic are these wonderful medications. And I'd say they're one of the best drugs in all of medicine because they're that effective. If it's more advanced disease and someone has some scar tissue growing, then surgery is a good option. And I've seen people go from being blind to seeing 20/20 with surgery. So it can be very, very dramatic, the visual improvement.
Okay, this is the last one. It's in a little bit of a different field, or I guess we're going a different way here. The question is actually a little bit more broad, saying, while they appreciate learning about retinopathy, are there other types of vision impairments that type 1s experience?
That type 1 diabetics experience.
Yeah, sorry, type 1 diabetics, yes.
Yeah, type 1 diabetics can get cataracts. And they have very pretty cataracts, actually. A lot of them have like a little snowflake cataract, we call it. The typical age-related cataract that the rest of the population gets is very slow to develop in a diabetic eye, which is interesting. And we attribute that to the fact that oxygen induces cataract formation. And in a diabetic, there's often poor circulation and lower levels of oxygen. So in that respect, they're protected from the traditional type of cataract, but they do get other kinds of cataracts that may necessitate cataract surgery at an early age. And I've certainly seen a fair number of those. Some people say glaucoma is more common with diabetics. I don't typically see much of that, but it can be. It's not real common.
It seems like most of those that have joined or asking questions are curious about their own experiences. So one last question, and again, you may have already answered this because they're kind of overlapping. Are there specific risk factors that I need to be aware of to help? They basically don't want to get retinopathy. So the question is, what are the risk factors they need to be aware of developing retinopathy as a type 1 diabetic?
Well, the biggest risk factor is their glucose control. All right, if their hemoglobin A1Cs are 9 or 10, they're going to get retinopathy relatively early. If they can keep their hemoglobin A1C levels very low, close to the normal range, they may never get retinopathy. It's as simple as that. And I think these glucose monitor devices and these these insulin pumps, they're just a miracle for this group of people. It'll make it so much easier to maintain good control over the glucose levels. I see a lot of patients with those monitors and the pumps, and they do very, very well on that combination.
Well, great. Well, at this point, I don't see any more questions coming in. So if either of you have anything else to say, this would be the chance for you to say it. Otherwise, we want to say thank you so much for joining us and for providing such incredible information and updates on this exciting research. I want to say again, Casey Davis, the interim executive of Diabetes Research Connection. So please check out Dr. Vinberg's project on our website. That's www.diabetesresearchconnection.org. We will follow up with you all with an email to provide the exact link, but you can see his project titled Preserving Retinal Cells Survival and Function for Potential Clinical Studies in Type 1 Diabetes. This is an incredible project, and DRC is honored to get to be a part of it. If you actually get to see his project page, you'll see a description of his project, a video, you can receive research updates. So please visit, we'll send you the information, and we hope that this gathering will produce more support for this incredible new research. So thank you so much, everyone.
Yeah, thank you, Casey, and thank you for DRC for the support.
Yeah, they've been a wonderful, wonderful support for us. We couldn't do it without them.
Yep.